phase in percutaneous surgery in this session of complications. Failures in foot surgery are not a new invention of percutaneous surgery. The complications we know from open surgery also apply to minimally invasive surgery. Nevertheless, we have to face complications in MIS which are uncommon in open procedures, so we need to know and to inform the patient. What is the evidence we have? We heard the facts from François and Olivier before, and generally speaking, we can expect equal or better results in MIS compared to open surgery. Scars will be smaller and the range of motion better for the dorsal extension in the forefoot. Also, MIS will have less wound healing complications, and these are the more or less clear data. For other complications like neuropathies or chronic pain syndrome, further evidence is needed. Also for the recovery time, but here data suggests that in the unfixed osteotomies like Isham Reberler and DMMO, there is a higher risk for delayed union than in the fixed techniques. In the wet lab courses, we always hear that the beginner is afraid of the burr. Will soft tissues like tendons and nerves be wrapped up by the burr? Is there a higher risk for malunion or non-union? Do we have the evidence to know what the burr does? In MIS calcaneal osteotomies, there is a cadaver study with 13 fresh frozen cadaveric specimens, and 11 ortho consultants without MES experience. With the incisions on the lateral side, it's easy to avoid the lateral calcaneal branch of the suralis nerve by cutting only the skin and preparing bluntly. In all specimens, the path of the osteotomy medially was near the tibial nerve and the medial calcaneal nerve branch, but none were damaged in any specimen. This could seem strange, but the medial head of the quadratus plantae muscle had an important function as a spacer between the osteotomized medial calcaneal wall and the nerves. We know the few comparative level 2 and 3 studies about the hallux valgus techniques. They display a steep associated learning curve. However, the results are promising. And the learning curve is comparable to that for open hallux valgus surgery. Even Trinka assumed that the reported complications seem to be less than one may see in one's own open surgery practice. So, there's no increased risk of tendon or nerve lesions in cadaver experiments or clinical studies. There is still the risk of skin burns for the learning curve with prolonged secretion. The tips to avoid this is to know well the anatomy and to be experienced in open surgery. We have to train in the cadaver labs and use new burrs, not used ones. For the motors, we need a low speed and high torque motor, and cooling and rinsing is essential. If possible, do the MIS without tourniquet and untighten the structures at risk. In case we have a soft tissue complication, we should excise the skin burns, for example. Tendon lesions are really rare and clinically silent. For the rest of soft tissue complications, we should treat them the same way as when surgery was performed open. What about avascular necrosis of the first metatarsal head? In studies of open surgery, AVN is reported in up to 40% of cases, probably depending on lesions of medial and lateral arteries. And in MIS hallux surgery, no lesions of the anterior plexus was found in Dukaram's cadaver study, and no avascular necrosis in Giannini's study with thousands of seriosteotomies. Jones postulated that extraarticular osteotomies like seri or scarf leave the joint capsula intact, avoiding damage to the network of vessels. In most MIS hallux techniques like seri, chevron, or proximal closing wedge of MT1, the osteotomy is extracapsular. Only in the Schönreberdan technique, the osteotomy is intra-articular. Nevertheless, the minimal invasive approach only from medial in the Eichhorn hallux osteotomy preserves the lateral vessels. In distal metatarsals, the situation is different because of the vascular anatomy. We heard about that. But even in open intra-articular live osteotomy, AVN is rare and makes less problems than one might estimate. Probably the extensive extraosseous arterial network around the head saves us here from major problems. In conclusion, a vascular necrosis in percutaneous surgery is rare as in open surgery. Tips to avoid it is to respect the head vascularization, avoid terminal injury by cooling, and if possible stay extra-articular. If you have an AVN, mostly conservative treatment is applied in hallux cases, and P1 fusion is the best, and for lesser metatarsals, it's as for the same complication when surgery was performed open. Now let's talk about dislocation and malunion. First, in hallux rigidus MIS of the distal metatarsal, like proposed in this book by Mariana Leprano. This is an incomplete, unfixed dorsal osteotomy to decompress the TP1 joint. But if the plantar hinge breaks, there will be excessive shortening. Obviously, after time transfer metatarsalgia can be the consequence. In this case, fixation will be preferable. This patient did well during follow-up in the TP1 joint, and the transfer metatarsalgia after 2 years was okay with inserts. Now for dislocations in MIS hallux valgus surgery. Possible mistakes are planning the wrong plane. We have to consider the bone loss by the burr of 2 to 3 millimeters. So plan lengthening and plantarization by the direction of the osteotomy. Also rotation and control of the distal metatarsal articular angle must be taken in consideration. We will hear more of that tomorrow in the hallux valgus session. Another problem is if the intention was good, but the cut is not in the anticipated plane. Again, we can avoid these mistakes by exercising the cadaver lab and do the osteotomy under fluoroscopic control. Malreduction can also result from unstable osteotomies and insufficient fixation. So fix unstable osteotomies by stable osteosynthesis as proposed in third generation MIS hallux. And also most important, take care of the postoperative dressings. This case is interesting. Will that heal? Well, these were not the MMOs, but a marathon run. And what does nature do in this situation? Does she need a fixation? Not at all. Osseous consolidation in normal time after 3 months. A case with pes adductus, metatarsalgia, and lateral deviation of the lesser toes. Expectation of malunion is fairly high with open, rigidly fixed surgery. So let's see with MIS. It's fairly common for some lateral displacement of the MMOs, as we heard. The second and the third. The fourth normally remains neutral, and the fifth always displays medially if performed. The reason is the pull of the tendons, which displays the head laterally and rotates them externally. In addition, the surgeon should be cautious of using DMMOs in the presence of simultaneous hallux valgus correction, as in the lateralization of the first metatarsal head tends to increase the tendency for the lesser head to displace laterally, and can also result in some early recurrence of the hallux valgus and widening of the forefoot, unless you do a good postoperative dressing. In summary, for MIS and malunion in hallux surgery, we must control the plane, rotation, DMMA, length and plantarization. In incomplete closing wedge osteotomies like the Prados rigidus or Isham-Reverdan for hallux valgus, we don't need fixation. Unstable osteotomies are fixed with osteosynthesis, and consider the new headless screws with angled heads. For mis-malunion in the MMOs, we have no fixation, so metatarsal head position adjusts with postoperative weight bearing. An incomplete osteotomy may inhibit free head adjustment, so test this after the osteotomy and palpate it. The tendon pulls can shift the head laterally, as we saw, and the choice of the osteotomy plane and postoperative dressing are also directing the head displacement. Here, the important thing is that head displacement on postoperative X-ray may be misinterpreted by those not experiencing MIS surgery. So inform the patient and your radiologist. Transfer metatarsalgia most commonly occurs when only selected rays are addressed. We heard that, so there's a low threshold to perform DMMOs 2 to 4 or even 5. And for transfer metatarsalgia after the DMMO, we can redo the DMMOs like we heard, or selective over. Last now for delayed and non-union MIS. A case with hallux valgus and pes adductus, radiologic follow-up after 6 weeks. The patient had a crunch when walking barefoot to the toilet. Will that heal? I think the problem was not only the pull of the tendons, probably the osteotomy was too proximal and oblique to lateral. After 3 months, she still was swollen but pain-free, and luckily she was consolidated after 6 months. This is a case of an older patient with diabetes and mechanical metatarsalgia, and maybe here the fault of an intra-articular osteotomy, or we should have addressed also the first ray to stabilize the hallux limitus. At 6 months there was obvious resorption. Only lately at 13 months consolidation was starting. He had swelling but no pain. There was a late diagnosis of diabetes mellitus and vascular disease, and probably he has more distal polyneuropathy than one might think. Or our board was not so new and got too hot. To avoid these problems in the MMOs, we have to check the vascular status and no internal injury, like I said. All these points help us by dealing with delayed unions which are under 5%. It's about saving time or not, but if we are patient and wait, mostly the swelling is the only problem the patients have. And dealing with non-unions, which are more seldom even, is to think twice before open revision, as most delayed unions fuse by 12 to 18 months. And the price of an open revision like this may be loss of motion due to scarring. In conclusion, results and complication rates of MIS and open techniques seem comparable, but further evidence is required. We aim for better results with MIS, however, proof is lacking. Be aware of pitfalls to avoid complications. The price of DMMO is the higher risk for delayed union, however, symptoms commonly are mild and non-union is rare. The amount of displacement and the time of consolidation may differ from what we are used to from open surgery, but be aware and relax. Thank you very much.